Thank you all for being here and for inviting me to speak this morning. I hope it will be an interesting and informative session for you. I think all of us in researching long COVID know we need to be flexible, so when they asked me to go first, that was no problem. I don't have any formal disclosures, but just wanted to acknowledge that our research is funded by our large tri-agency, the CIHR, and the Long COVID Web, which is our national research network, which is also CIHR funded, provided some funding for our work, and I receive salary support from our practice plan at the Department of Medicine. So 3 simple objectives this morning. I want to introduce you to a recently published causal framework that can be used for non-randomized studies. I would like to highlight that using big data and large administrative data sets can really help us start to get at answering causal questions in the modern times. And I'm going to introduce you to 3 analytical methods that can be used to support causal inference within this framework. So this number is probably a large gross underestimate given lack of testing, but the current reports are we're approaching 1 billion people across the globe who have been infected with SARS-CoV-2. And no matter what fraction of those you decide to call incident long COVID, that number stands to be a huge amount of people that will be suffering with persistent symptoms and chronic conditions. And yesterday we heard some nice reminders that COVID is not going away as much as we would love it to. And so I was able to pull some recent data from the CDC. On the green line shows you COVID-associated hospitalizations last year. And the red line is this year's trends, and it's likely history will repeat itself in the coming fall season where we'll see a recurrent surge and hopefully continues to be smaller and smaller each year, but still a major health issue that we deal with. And several of these individuals, unfortunately, will go on to develop persistent symptoms and chronic health conditions as a result. So this goes back a few years, and all of you, I'm sure, are familiar with these studies. We watched with great envy and admiration as Dr. Ali started to publish these papers on post-acute sequelae of COVID. And if you have a really great data set and a really talented team, you can start to put out other studies looking at cardiovascular sequelae and other studies looking at endocrine sequelae and more studies looking at mental health sequelae and even more studies looking at neurological sequelae. And so it's a really great body of work that we watched. Again, the data set was available and they had this great idea and really helped forge the field in this area. And I guess that's how you get your picture on the Time 100 top people in health, but really a really great effort. And we saw these coming out and thinking, that is an enormous number of sequelae for a single disease. Could it be that there is something unique about COVID or SARS-CoV-2 that's driving all of this? Is it causing all of this, or is there something else going on? And certainly, we've seen these, and there was nice discussions of this in the yesterday's sessions, these unexplained post-acute infectious syndromes over time. And you can pull news reports from 140 years ago almost, where people were having persistent symptoms after the Russian flu. And then earlier in this century with the Spanish flu pandemic, we actually heard about atypical poliomyelitis yesterday in some of the sessions. And even this new term, long flu, which also comes out of Dr. Ali's group, is potentially something to consider with these persistent symptoms and sequelae after infectious illnesses. So we paused and said, what's the cause and effect here? Is there something specific about SARS, or is there something else going on or partially contributing to some of these sequelae? And so I just wanted to introduce in JAMA, I think about 2 weeks ago now, the editors put forth this causal framework that they are proposing will allow researchers to use causal language in observational studies, non-randomized studies of interventions and other observational studies that meet a certain set of criteria. So I just wanted to highlight, a quote from their article, their editorial, that well-conducted RCTs remain the preferred approach, and obviously because it balances measured and unmeasured confounders to answer causal questions. But methods for observational studies have advanced so much such that causal interpretations of the results of well-conducted observational studies may be possible when strong assumptions hold. And I think it's the assumptions that we all need to be aware of and plan for and are really important. So they proposed these 6 questions. I'm not going to go through them in great detail, but I encourage you to read their article. It's quite interesting, and they have some figures to help unpack that. But I think any of us who do observational work, understand all the risks of confounding and other sources of bias. And these questions effectively walk you through that and try to make you ensure that your study design and planning and data collection are sufficient as such to address all of these, such that when you arrive at an association, you may actually be able to infer causality across them. And now we live in an era where we have enormous data sets. In Ontario and in Canada, where I'm from, we have the luxury of having a universal healthcare system, and we do collect routine administrative data on all healthcare encounters. And then using these encounters, we can link people's individual selves in an anonymous way to other large databases around census data, sociodemographics, education sometimes, workforce planning. All of these different databases that exist can be linked, and you can use these data to really get a comprehensive look at somebody and their outcomes. And we do that at ICES in Ontario, but there are many other provinces and territories across Canada that that have these data available. And actually several other nations around the world now have population level data for their countries as well. So it's a promising and exciting time to be able to study populations and using extremely large data sets to do so. A caution, though, that the use of these data sets requires a team. Research is definitely a team sport in the current age. There's this concept of a unicorn. I am definitely not one. The unicorn is somebody who can do everything. They're an expert statistician. They know how to code. They have lived experience, and they are the expert in the world on that subject matter. I sort of fit partially into the bottom right corner there as a diverse team of clinicians and scientists. And so we partner with expert statisticians who help us with this, to senior analysts who can speak several different coding languages and know how to run these types of analyses. And most importantly, we have several patient and caregiver partners with lived experience who really help inform our questions from the outset and help us with the interpretation and messaging of what we find. So moving on to some of the studies that really caught our attention and got us thinking about causal inference. This was the first study that really caught our eye. And it's actually with sequelae of acute COVID, not long-term. But this group in the BMJ published their risks of different types of blood clots that form in the veins of our body, so venous thromboembolism, just a medical term, and they're in the lungs as a pulmonary embolism, and in your legs as a deep vein thrombosis. And they used this design called a self-controlled case series. And so we thought, this is a pretty neat design. What's under the hood? And so a self-controlled case series is really useful when you have a discrete event, such as a SARS infection that you know and can prove with administrative data that it happened. And previously, there was a lot of testing going on with PCR, and those were captured in different databases, so you could prove that somebody had an infection. And the way that a self-controlled case series works is that instead of looking at people who are similar to myself, I am my own control. And so you look at 2 separate control intervals, the before the event, and then for some period after the event. And then you have a risk interval that you define where I am at risk of developing, I have the event, and then I am at risk of developing the condition or outcome of interest. And you look at the incident rates between the before and after to the risk period. And so it's really nice because all of the things about myself that don't change will be controlled perfectly because I am a perfect match to myself. But the main assumption for this particular approach is that there are no time-varying factors about me that will change over time. And of course, we recognize that's not necessarily true. If something happens to me, there might be a whole bunch of other things that come as a consequence or a domino effect. And those other things that happen to me may actually influence my likelihood of treatment or my likelihood of various different outcomes. So you have to be aware and thinking about those types of time-varying factors. The other thing is it's a much better a design for shorter intervals to minimize the risk of those time-varying confounders that come up. So when we were starting to think about, well, let's look at the long-term effects and decide if these are truly caused by SARS-CoV-2, this may not be the best design because of that long post-exposure period, a lot of things can happen to people, and that may or may not influence the risk of the outcomes that we're interested in. So it's a really nice design, and you can have some really powerful causal inferences, but it's better for discrete events with a shorter follow-up. And so we decided not to use this, but I do think it's helpful to think about in your designs for other types of questions. And what this group showed, I'll just highlight in the red on the bottom. The SCCS is the self-controlled case series. They also did it using a matched cohort, so to look at more traditional types of matching strategies. And they found that in the first acute window, within 90 days of COVID, there was a much higher incident rate of these thrombotic events in people compared to themselves in the pre and post controller intervals or matched controls who didn't have SARS-CoV-2 infection. So we thought, okay, well, that's not necessarily the best approach, but we have some other approaches we think that would be more tenable for this type of an analysis. And Dr. Chung, who's also with us today and will speak a little later, co-authored this study with us and a group of us in Toronto. And it was published last year in JAMA Internal Medicine. And we thought, there's all of these sequelae. These sequelae are major chronic health conditions. They have huge impacts on people as well as our health systems and costs. So let's try to disentangle some of the effects of COVID from other causes, and that's what we looked at in this paper. And it was founded in our underlying framework from a condition that Dr. Krumholtz proposed a long time ago, 11 years ago now, this concept of a post-hospital syndrome. And for those of you who are familiar with intensive care or critical care, there's also a post-ICU syndrome, which our colleagues, Mark Herridge in Toronto, has really done a great job describing and studying. But we thought people who go into hospital, where I work and look after a lot of on the internal medicine wards, they often have these long-term sequelae, and it kind of seems to be regardless of whatever they came in for. So we thought maybe there's something that's going on with this effect in COVID, or maybe not. That's what we wanted to explore. So we asked in this study, is the risk of newly developing, so incident conditions that were not present previously, and we looked at a range of 13 conditions that were chronic conditions that were associated with poor quality of life and high healthcare use, and for which in our administrative data we had validated case ascertainment algorithms. Because remember that administrative data is not really intended for research by design. It's a billing and statistics for the health system type of data. So it's really important that what you're measuring is accurately validated to ensure that there's no misclassification or other types of bias introduced. So we chose these 13 conditions based on those criteria, and we looked over a course of 1 year following hospitalization for COVID. And we thought, what would be good comparator groups? So we chose three actually, but two separate conditions. Influenza as a severe respiratory infection that we see lots of people through the hospital with. And then sepsis, which is a serious blood infection. It's a heterogeneous type of infection. It can be caused by many different pathogens, but people get very, very sick with sepsis. Influenza disappeared in Ontario and I think many jurisdictions during the early phases of the pandemic. It was outcompeted by SARS-CoV-2. So we looked at historical comparators with influenza. Sepsis did not disappear, so we looked at two groups, one historical and one during the same time period as our COVID group, and obviously excluding anybody with COVID who might be sick and called sepsis from that sepsis group. And what we did to try to minimize all of these risks of bias and allow some causal inference is to use this technique that's relatively new, and it's on the family of propensity score approaches called propensity score overlap weighting. So what this is if you ever want to learn about a new statistical technique, JAMA methods to Guide to Statistics and Methods have amazing summaries of these. They're like a page and a half, and they really give you sort of the concepts. And this is what this is from. So what propensity score overlap weighting does is it calculates a propensity score of somebody belonging to the other treatment group. And then based on that score, which goes from 0 to 1, it will weight the person's contribution to what they call a synthetic cohort. So you create a new cohort of these weighted individuals, and those who are, have a score of 1 will always get the treatment, and a score of 0 would always not get the treatment, and they're down weighted. And it's the people in the middle where you're not sure if they would or would not get the treatment, which is how it simulates randomization. those people are contribute the largest weights to the overall cohort. And so on the left, you see the unweighted cohort of people with diabetes. In orange are the people who received an ACE inhibitor, a type of blood pressure medication. And in the blue are people who didn't receive. And so there are, differences in age and other factors. When you apply these weighting techniques, and so you see on the right, the middle panel there's different circles of different sizes because each person is contributing a different weight to the synthetic cohort. On the right, then you see in these example characteristics at the baseline that they measured on age, BMI, and other conditions, the blue dots are actually the standardized differences between the weighted group. And it's all 0, meaning that there is no difference between those two. Whereas in the triangles, you can see these large differences if you didn't weight them. So what it gives you is a really nice simulation of randomization by balancing all of the measured factors at baseline. In that way, you can help to overcome the indication bias, why somebody may or may not be treated with a particular treatment, in this case, a medication. And of course, the main assumption here is that that the treatment assignment, whether they got that treatment or not, is independent of the measured outcomes. So in other words, that you didn't miss any significant factors in your propensity score that would have related to those outcomes or their treatment assignment, which is what randomization takes care of. But in this case, if you have enough measures and you're confident that you haven't missed any major factors, then it simulates that and it serves as a surrogate. And so this is our table 1 of our baseline. So this is looking at the COVID group compared to the contemporary sepsis group across a whole host of measures. We had some others, but I didn't squeeze them onto the slide. But you see on the far right, the standardized difference is 0. And we don't use t-tests and p-values because when you have such large sample sizes, everything is statistically significant, even if it's tiny differences. So we use standardized differences, and this is a well-recognized method to do so. It was so much so that actually after the proof was through into JAMA, the editor emailed us and said, I think there's a mistake, guys. Your table is identical. The numbers are identical between the two groups. I think you've made a mistake. And we said, no, this is the synthetic weighted cohort. The unweighted is published in the supplementary. And they're like, oh, whoops. Okay. So anyways, again, we're looking at 5 conditions, not all 13 for the sake of time. But what you see in the orange are the influenza. The blue is the historical sepsis, and the dark blue is the contemporary sepsis groups compared to the COVID groups. And effectively, across all of these different conditions, we didn't see an elevated risk for any of these chronic conditions incidentally developing after hospitalization, except for venous thromboembolism, particularly in the comparison to historical influenza. And when we looked at the timing of that, it was much more upfront within those first 90 days, consistent with what the group in BMJ had published, although over a year's period, there's still an elevated risk regardless. So what we concluded from this study was that many of these post-acute sequelae, not symptoms, but chronic conditions that are part of the PASC definitions from the CDC, may be related or partially related to the underlying severity of the infectious illness, not something specifically unique to COVID itself. Obviously, COVID is contributing to this because people are getting this sick from COVID, but it's not that it's above and beyond these other severe infectious illnesses that people are hospitalized. When we looked at just overall rates compared to the background rates in the general population, across all of the groups in our study, the rates of these conditions were still significantly elevated compared to the general population. So there's something about getting that sick and all of the disturbances in your body that happen as a consequence of that lead to these chronic conditions. Lastly, another really nice way you can use these advanced techniques is to actually look at drug interventions to either inform and answer questions of causality or at least to inform the design and conduct of clinical trials. And so this group did a nice, what's called the target trial emulation to look at the effectiveness of Paxlovid against these chronic conditions. And I won't take you through this busy slide, but effectively a target trial emulation, you think about an actual clinical trial if you were going to do it, and that serves as your PICO, your population intervention comparators and outcomes, and the timing of that. And then in this study, they actually looked at sort of almost 5 different groups, people who got Paxlovid on day 0 and 1 of their infection, day 2, 3, 4, 5. And we know that Paxlovid is most beneficial from the efficacy trials if given within 5 days of infection. And then they used those same techniques that I just introduced you, the various propensity score matching techniques to overcome the indication bias between who did and who didn't get Paxlovid on those different days. And they looked at the outcomes between a month and 6 months. Excuse me, the assumptions for this type of approach is the same as propensity score, overlap weighting, and other methods, that treatment assignment is independent of other potential outcomes. And so what this group showed that again, they measured, in this case, 31 potential post-COVID conditions, and this is in VA data, that the only one that was lowered as a risk was thromboembolic events, like venous thromboembolism, and Paxlovid appeared to be contributing to a lower risk of that in people who received it compared to those who did not. And so that led us to say, I think that we're ready to look at interventional trials now, and we are about to launch, just getting finalized approval, a trial we call DEFEND. By the way, if you're looking for these fancy names, ChatGPT is very helpful at coming up with acronyms, even though the letters are just various spots in the words. We thought it was kind of nice to talk about prevention, and we're defending against COVID. And we're looking at actually an antiviral hypothesis, so randomizing people to Paxlovid or remdesivir in hospital, and we're looking at the prevention of these chronic serious health conditions. And so we'll be hopefully able to present some of those findings to you in the coming future. The other thing I wanted to mention about clinical trials and the use of administrative data is trials cost a lot of money, and the cost often comes from the people who you need, your research coordinators, to run those trials. So administrative data gives us an opportunity to measure and determine different aspects of trials. So there's been several trials recently who have used administrative data for outcome ascertainment, and we will do that in our study, similar to what we did in our JAMA paper. But also we have a new database that gives us the details of what happens in the hospital, medications, vital signs, all of these things. And so part of our trial is going to validate the measurement of those trial processes, treatment randomization, co-interventions, et cetera. And then that will, again, in the future, hopefully improve the efficiency from an economical standpoint to measure these things using administrative data over the use of humans that cost money. And then in Canada, we have a new national network called the Health Data Research Network that's enabling and facilitating cross-jurisdictional linkage between the provinces and territories of all of our population-level data, so that we'll be able to do these types of things on a national scale. So the future is exciting and bright, and I think, again, just demonstrates the power of administrative data. So I'll just finish with a couple of summary points. The availability and increasing availability across the world of countries with different population-level data sources, combined now with these advanced analytical techniques that we have, I think really give us a strong opportunity to answer a lot of clinical questions that sometimes are not even amenable to a trial. And we can look at these in different ways with these big data sets. Then the framework that JAMA published and I introduced you to, I think, is really helpful to keep in mind when you're designing and reporting causal effects from these non-randomized studies. And our work has helped to disentangle some of those effects of COVID specifically from other acute infectious illnesses, and that some of these sequelae may not be specific to COVID itself. Nevertheless, the magnitude of the number of people who are developing sequelae because of the magnitude of infections, and the fact that we might be able to do something about this. We can't necessarily do something about sepsis or influenza in the current times, but we have targets for prevention and intervention with COVID that bears further study. And that's what we're looking at with our DEFEND clinical trial, is the prevention with the use of these antiviral medications. So with that, I'll thank you all for your attention, and I'm not sure when the questions and period will start, but I appreciate your attention and your attendance this morning.